Good evening. This is Dr. Bitton from Manhattan Orthopedic Spine in Manhattan. And this is one of these sessions where we're going to develop a topic that could be of interest for people in the public. Tonight, I'm going to talk about artificial disc of the cervical spine. Artificial disc has come on the market like 20 years ago in Europe and then in this country. There have been a lot of questions and controversies about them, and I personally have a significant experience. I've been being trained in Europe and then here, and I want to share that with you a little bit. I selected the most common question that patients ask me when I see them in the office, and I'm going to summarize them in this slide. These are the questions. What are the most common treatments available when somebody has a cervical spine problem? The second question is, when do a patient need to have an operation as opposed to other type of treatment? What are the traditional surgical technique? And what is the advantage of an artificial disc over a spinal fusion? And then we go over a more specific question about, does everyone qualify for a cervical disc? And also, what are the risks of this procedure, how long the disc lasts, and also what are the financial implications of having an artificial disc done? We're going to go over all these questions very quickly. First of all, what non-operative treatment are available? When you have a neck problem due to a herniated disc or other condition, you don't necessarily need an operation. In many cases, this can be handled by other type of treatment, such as a rest, wearing a cervical collar, sometimes mild medication, a little bit of traction, acupuncture helps, physical therapy can help. And actually, most patients do well with these techniques. In most advanced cases, sometimes we can do injection of steroids around the cervical spine to alleviate the inflammation. So when do we need an operation? You can see on this slide that there are many conditions, and one of them is herniated disc. A disc is a cushion between the bone of your spine, and this cushion is like a shock absorber, a little bit like the suspension of your car. And unfortunately, sometimes this breaks, and a fragment of this jelly that inside the disc comes out and can compress the nerve. This is a disc herniation. In other cases, you can see in this slide, there's no disc herniation, but the disc wears off over the years and creates some bone spurs that could press on your nerve. All these, and we call that osteophytes, bone spurs. Bulging disc is just a very small disc herniation. So in all these conditions, if all the treatment have failed, you can become a good candidate for an operation. The most common operation on the cervical spine is what's called a spinal fusion. And you can see on this slide that an example of spinal fusion. When you do a spinal fusion, first of all, you remove the bad disc, the broken disc. You relieve the pressure on the nerves from the disc herniation. But then you have to fill the space with something. And you fill it with a piece of bone, and there are many sources for that. And then you have to fix this piece of bone with small screws. You can see that on these x-rays and on this slide. Eventually, the bone that you put between the vertebrae is going to heal the two bones together, and these two vertebrae will form only one big bone. You're going to lose the motion at one level of your spine, which is not a big deal initially because the other disc will compensate. But there is a risk that in the future, because you're putting more stress on the adjacent disc, that this disc might wear off as well. And it's not uncommon after spinal fusion to see the patient come back after 2, 5, or 10 years to have another operation at another level. And actually, some studies have shown that at 10 years, probably 20% or 27% of the patient needs to have an operation at another level. There is another operation we can do on some patient, and in very specific indication. And as you can see on this slide, it's called foraminotomy. It's a difficult term, which means opening of the nerve canal. This is what I mean. And you can see on the upper right picture of this slide that the nerve canal normally is very wide and give a lot of room for the nerve to travel. You can see at the bottom left an example of narrowing of the canal. And the nerve can be crushed in this canal by the bone and the disc. So basically, the foraminotomy consists in reopening this canal. We use very small burrs, just like a dentist would use to do a root canal. This works well when you have only one or two nerves compressed and you have no other problem. These are the treatment. You can see here the foraminotomy on the left side, and you can see the spinal cervical fusion on the right side. Now, this slide shows you an artificial disc. This is the newest treatment in cervical spine surgery, and this, as I said, comes from Europe, and it's been around for more than 20 years now. There have been several studies showing that the result on neck pain is as good as the spinal fusion, but the result long-term is better in a sense that the artificial disc doesn't give the 27% risk of having another operation. And actually, the risk with artificial disc is actually extremely low, and in my own experience, it's like not more than 3 or 5%. This is what an artificial disc looks like. You can see on this slide that a patient who had an artificial disc many years ago, when you get an X-ray with the head bending backward and forward, that the disc move actually in flexion and extension. Doing this, it prevents overloading the disc above. Every patient who comes to the office with a cervical problem, I've heard about my involvement in the artificial disc world, and they all want an artificial disc. Unfortunately, it doesn't work that way. And as a matter of fact, very few patients qualify for an artificial disc. And the criteria are quite strict. First of all, the FDA approved this device many years ago, but approved it mostly for one level. What does that mean? It doesn't mean we cannot use it for 2 levels. It just means that the FDA has not tested the product for 2 levels. And if you have a 2-level disease and you need 2 artificial discs, then you need to understand that this is the judgment of your surgeon that you might qualify for this procedure. The other thing that the FDA did not test is the association of an artificial disc with a fusion. For example, imagine you had a fusion of the one level of your neck, and 5 years later you have a problem at the level above. Then you can have an artificial disc at the level above. This is actually a very good indication, and it works very well. The FDA didn't test this, so you have to understand that, again, you have to trust your surgeon's judgment. Severe osteoporosis is traditionally not a good indication for an artificial disc, although it has been done, especially in Europe, with no major complication. Now, what are the risks of the cervical artificial disc replacement that we call routinely A.D.R? First of all, it's an operation from the front of your neck, just like a fusion. You go through a small incision in the front of your neck, you move all the organs out of the way, you get to the spine, and you take the bad disc out. You clean the space between the 2 bones. This cleaning has to be very meticulous, and it's exactly the same whether you do a fusion or an artificial disc. The operation is the same. The only difference is, instead of putting a piece of bone that's going to weld the 2 bones together, I'm going to put a piece that is articulated and I'm going to give you back the normal motion. So the operation is the same as a fusion. What the difference is what I put in the space. That's why the complications are very similar to a fusion, and the only thing specific to an artificial disc is actually the risk of having the piece coming out. And usually this doesn't happen. And actually, to tell the truth, I've been involved for 10 years in artificial disc, and I never had a disc coming out of the neck after it's been implanted. I think it's probably a technical issue, and by being meticulous and by following the rules, then we can avoid this problem. The other complication are the usual complication of cervical spine surgery, which is the injury of a small nerve in the neck that could control your vocal cord and have a change in your voice. The risk of nerve injury, of spinal cord injury, of course, is real, but it's extremely rare. And I've been practicing 25 years, never had this happening. But it can still happen. I like to compare this like taking a plane and having a crash. We still all go on vacation and we fly, even though we know that it's a remote possibility. The last question is, how long does this disc last? It's hard to answer because those discs have been around only for 20 years, and they're still in there, and most of them are working pretty well. How long are they going to last? If you, for example, if you do a patient who's 30 years old, are we sure that this piece is going to last for 70 years? That I don't know. I cannot answer that. However, the conversion between an artificial disc to a fusion, in case something happened to the disc, is actually very easy. So even if the disc, after a long period of time, wears off and the plastic breaks, it wouldn't be a very big problem to remove it, to remove it and to replace it with a fusion anyway. What is the insurance issue? Most insurance companies, until recently, did not cover the cost of this artificial disc. They consider it investigational, experimental, which they are not. They've been approved by the FDA and they've been used throughout the world for more than 20 years. But that was the insurance policy. Things are changing gradually, and we see more and more insurance covering this device, as long as you remain within the restriction of the FDA. One level, no fusion associated. As long as when you get out of this restriction, if you want to do a 2-level, if you want to combine an artificial disc and a fusion, most insurance companies will not cover, and that would be an out-of-pocket expense. The out-of-pocket expense includes 3 parts. Number 1, the hospital cost, which is usually the biggest part of the bill. Number 2, the cost of the device. And number 3, the fee of the medical team. This could be discussed directly with our billing department. And, but most of the time, we can find a way to make this work. If you have any other question, feel free to contact us through the website or calling the office. Thank you.